welcome everyone. Good evening. We're here at tonight's GP Masterclass. There are no naughty or normal kids. Just moving on to the next slide. Just like to start tonight's meeting by acknowledging the traditional owners and custodians of the lands on which we all meet tonight. I pay respects to all First Nations people and acknowledge elders past, present and emerging, and recognise the continuing connection to land, water, culture and community. I extend that respect and warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. Thank you for joining us. Just a little bit of housekeeping. There will be opportunities to have a question and answer sessions, a couple of breaks throughout tonight's discussion. If you can pop your questions into the Q&A box, that'd be fantastic. Or if you'd like to ask your question verbally, you're quite welcome to use the raise hand button as well. Just to let you know that tonight's session is being recorded so that others will have the ability to benefit from tonight's teaching at a later time and date. So I'm very privileged to welcome Dr. Stuart Crisp, General Paediatrician, to deliver the main bulk of tonight's session. Dr. Crisp is a paediatrician who's been based in Orange for the past 13 years. And previously a VMO in Wangaratta after completing training in the UK. Stuart is married with 3 children who are presently in Canberra, Rotterdam and London, so there's plenty of excuses for travel. He's a self-confessed cricket tragic who has played over 50s for Australia. His activity has been cut short due to a bicycle accident back in November, so he's recently seen the other side of medicine. Joining us later in the program will be Tammy O'Connor, Senior Manager of Paediatric Child and Family Wellness, Western New South Wales Local Health District, and Sonia Wainwright, RuralKidsGPS Care Coordinator, to share information about the new RuralKidsGPS Paediatric Care Coordination Service. Stuart, Tammy and Sonia will all participate in the Q&A session at the end of tonight.
Very shortly, won't be a moment. Okay, bye.
Are we right, Erica? Okay, handing across to you, Erica. We've got our screen. Okay, moving on. Over to you, Stuart.
Well, thank you. Thank you for the invitation to come and talk. I will hopefully explain why I don't think there are any normal or naughty children particularly. We're going to cover quite a lot tonight. So it's going to be high speed. I sent the handouts beforehand so that you could have them in front of you if you wanted to. You can obviously get copies at the end because I've hopefully given you a reasonably comprehensive handout, and then I can skip some of those slides because I want to make sure there's plenty of time for questions. So that's what we're going to cover. Autism, which I will just call autism. ADHD, which I will just call ADHD, but it includes ADD. And my primary objective, if you like, for tonight is to try and explain from a paediatric point of view, from my paediatric desk here, what I hope to get from a GP and what I think families want to get from a GP when their children have these issues. There'll be a couple of opportunities throughout to ask questions, and then we can do that at the end as well. So there are your learning objectives, which hopefully we will meet, but you can answer that at the end. So let's start with autism. Now, one of the problems with Zoom is that you're going to have to put up with my voice for quite a long time, so I apologise for that. If there's anything you really don't understand, then just jump in and interrupt me. Otherwise, I will just keep talking. So we all have our views of what autism is like, but simplistically, it's complicated. It doesn't go away, although it may change over time. It is a developmental problem, and it affects communication for the child and for those around them. they have developmental delays in those areas. And these are known as the triad of impairments. Think of it as those overlapping circles. So you can have each of those individually and they may not cause a problem, but it's when they overlap that they can be quite tricky. And then there's a whole heap of other things. So I'm going to expand on all of this as we go. Autism's common. It's getting commoner in terms of how often it's diagnosed. We're still not very good at diagnosing it. You know, the signs are there in lots of toddlers, and it usually takes till they're 3 or 4 before we make a diagnosis. And that's partly the incentive for talking about it tonight. But there are lots of numbers on that sheet you can have a look at. Golden question, what causes it? We don't know. It's a brain problem. It's a brain problem affected by both genetics and the environment. And if you look at those brains of children with autism, they're different, but they're not consistently different. And certainly an MRI isn't going to tell you the diagnosis. But it has got a genetic component. It's reasonably heritable, but without obvious single gene changes that cause autism. So it's likely to be polygenic. There's an association with Ehlers-Danlos, loss, which I don't really understand. The X chromosome is important, and I don't understand this slide either as to why whether you've got older or younger siblings with autism should affect your risk of having it, but that's what it is. So those are the genetic associations, and then there are the acquired forms, and they can be acquired through things that happen to mum, and so in utero changes, and obviously alcohol's probably top of that list in terms of frequency. And then there are things that can happen to the child. Obviously those are all genetic. Most children who are suffer hypoxia at birth are not going to have autism, so it's clearly not that straightforward. But there are lots of things that can lead to autism. And then there are these strange associations with immunological abnormalities, which I'm not going to go into particularly, except to say that the folate receptor alpha autoantibody thing, about which I know next to nothing, is quite interesting, because if you give folate, apparently to some children with autism, it makes a difference. Watch this space. I don't know if that study has been replicated, and it's certainly not mainstream, but it may be something a parent talks to you about. So how are we going to make a diagnosis of autism? That's what you're probably wanting to hear. Well, surprise, surprise, history examination investigations. Importantly, we want to know what the behavior is in different settings. Now, the stuff that I put in red is just kind of, if you forget all the rest, just remember the bits that are in red, because those are the most important bits, particularly in terms of what I think a GP can bring to these complicated kids. So we're looking at behavior in different settings. We may get some more detailed assessments. And that's remembering that this is a spectrum. That quote, I'm sure you've all heard, but it is absolutely true and important to remember. And we'll come back to the concept of a spectrum in the not too distant. But that spectrum is wide, and it has extremes at both ends, and we're in the middle, you, me, everyone else. And therein lies the challenge, because it's easy to say a child has severe autism. It's easy to say this child clearly has nothing suggestive of autism, but unfortunately we all live in the middle, and most of us have a few traits that are autistic. So one of the things I'm trying to do tonight is to show you how that normal overlaps with that we decide is not normal. So how are we going to decide what is normal? Well, that depends on your starting point. And it matters because the earlier we make the diagnosis, the better the outcome for the child. And there are lots of studies that go through why it's important. It's important for the families, it's important for the children. Genetic counselling is a minor issue, really. It's also important that you don't label somebody of having autism if they don't. And that probably the main reason for that is that labels stick, and it may mean that people stop looking for other things that they might be able to do something about, like a language or learning difficulty. So how are we going to make the diagnosis? We go back to this triad of impairments. Social. So some of these children will be very distant, very cold, but some will show some affection, and that's often to the closest family member. Affection, it's often very kind of formal and stiff and stilted. A parent who says to you, my child interacts in a very stilted kind of way, that should ring an alarm bell. And the reason for that is that children have this problem with theory of mind with autism. They can't respond or understand other people's feelings. They can't put themselves in other people's feet. And that explains a lot of the signs that we see. Moving on to communication. The important thing here is that these kids don't need communication. Some of them will have lots of words, but it's often very functional and it's on their terms. A reasonable number will have very poor speech. Some will have no speech at all. But those who do speak are not trying to have a conversation with you. They're just talking through you, around you, or they want you to do something. So it's really not about having a chat. And they can't use the non-verbal parts of communication either. Now, clearly Zoom is not a good way of trying to discuss non-verbal because you can't actually see what I'm doing with my hands most of the time. But that's a real problem for these guys because they're very difficult for their parents to read. Now, if they do have good vocabulary, it is often slightly unusual. It may have sound like they're on some American TV program. They may use very odd words, and we talk about them having unusual pragmatics. And the only people who can say that a child's pragmatics are not normal is a speech pathologist. And I'll come back to that in a moment. And then moving on to their imagination. Children with autism don't have particularly good imagination. Some don't play with toys at all. And some will play with a car, but instead of going brum, 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 I hope you can see this because I can't actually see myself, they play with the wheel. So they just simply play with the wheel for hours on end. And if you want them to then play with something different, you can often find it very difficult to move them on. And that's something that preschool teachers notice. Yeah, everyone else packs up and moves to the next room to do something else, and these children can't do that. But their play can actually be quite complex, but it's often repetitive, and they often lose that barrier between fiction and reality. So they'll do strange things because they just don't see that that's not the right thing to do. And if you have no imagination, you can't plan. You can't see what's going to happen next because to be able to do that, you have to imagine what's happening. And so their protective mechanism is to narrow down their interests, and that reduces their anxiety. And so they'll do the same thing over and over again. And you have this huge variety of stereotypies, repetitive behaviors. So it's this insistence on sameness. Things have to be the same. And that's true of all kids to some extent. That reduces everybody's anxiety, but it's just at that end of the spectrum for these kids. And so all of those things can happen, particularly the bottom one, attachment to an object. And I can assure you that in some children, it never goes away. And for some, actually, the attachment can be to a whole group of things that they have to have with them wherever they go. Those repetitive behaviors can include collecting things, and that can be almost anything, stones, bits of rubbish, or it may be something more socially acceptable, be it stamps or books or whatever it may be. And when they've got those, often children with autism like lining them up. And if you take them out of the line that they're supposed to be in, that causes them a great deal of distress. They also like their routines as part of these stereotypies, and that can occur at bedtime, where they have to have the same routine. but it can be more complex, either motor or sensory. They can become fascinated with certain things, so they become obsessed around any of the things that I've listed there. Thomas the Tank Engine is pretty high up on the list, and it's thought that that's because the faces are fixed, in the books at least. But I don't think anybody quite knows, but I can assure you that it is certainly in days, for probably a good 15 years, it was the top of the list by quite a long way. But they can be fascinated with absolutely anything. It really doesn't matter, and they will get fixated on that for months and months. They will sometimes then change, others will not. And then there's a whole heap of sensory things for the kids with autism. Some will not want touching at all. For others, it's much more firm touch that they need. For others, it's sensitivity, either hyper or hyposensitivity. Visual things, so often holding things very close in front of their eyes, staring at mirrors, flashing lights can be an obsession for some of these children. And they can be emotionally very volatile, and that can be very unpredictable and difficult for families. And then lots of motor issues. And then there's a whole heap of associations that are listed there. Epilepsy is one not to forget. And so I do warn parents with children with autism that they do have quite a significant increased risk of epilepsy. And then finally, we get onto the bit that everybody knows about, the amazing skills that some children have with autism. And it can cover almost anything. I've got presented with a beautiful painting. Here we go. Actually, here it is, by one of my children with autism. But it can be anything, including art. So I suspect that what you're sitting there thinking is going, well, yeah, but that's all normal behavior to a degree. And that's absolutely true. That is the problem. It is all normal to a degree. And in case you haven't realized, those are all photos of my kids, and I wouldn't say any of them have autism. So we're back to this spectrum, but I prefer this, and I think having a copy of this in your office somewhere to talk to parents about if they've got children with autism or adults with autism is quite helpful. It is a spectrum of spectrums, or spectra, and it just shows how wide that spectrum is. I'm going to these for time. The importance of knowing it's autism, as I said earlier, is so you don't miss other things that will need specific treatments. It's also important that we don't miss the comorbidities that go along with autism, and that's almost any mental health issue. I would probably have put that in the wrong order. Anxiety and depression should be top of that list. So how are we going to make a diagnosis? Well, we've got to see the child in action. And it's funny, in my room, kids behave incredibly well, much to their parents' disgust. And so you need to know what they're like in the classroom, but also in an unstructured environment like the playground, as well as at home. So that's quite a lot. And so we need to kind of just hone that down a bit. And this is all in the handout. These are the specific things that really should set some alarm bells ringing. Now, generally, parents will, or child maternal health nurses or playgroup will pick these things up, but these are things that if you're talking to parents, you would want to know about. And the ones in reds, I think, are ones that are slightly more discerning than others. So this guy narrowed it down a bit. Now, of course, that's fine. If you've got reasonably severe autism, you're likely to have those things going on. But lots of children are not particularly good with eye contact and may have other reasons for not coming when they're called. Pointing and showing is a skill that you have to learn. So none of these things are easy to discern sometimes. We talked about why it's important to make the diagnosis. And so there's a whole heap of screening tests available. I don't think any of them are particularly good because they're not they're a bit, well, it covers 25% of the population at least. There's a new one, that one at the bottom, the SACS, which apparently is much better than the rest. I couldn't say anything. You can go away and read the paper if you wish. But it says it's better at picking children up with autism than some of those other screeners. But what happens locally? Now, I realise that you're from everywhere, and I'm talking about Orange primarily and my practice and this region. But generally what happens is the parent will go to the GP and say, either we think there's a problem or someone else thinks there's a problem, and that often relates around speech. And I get a letter. Sometimes I get a very long, detailed letter, but I do get a fair number that says query autism. So what might you do when you're referring? Well, you might, if you had time, and I appreciate that time is critical in GP practices, but you might have a think back to the things I've just been through and take a detailed history and examine the child and make sure there's nothing untoward, ensure they've had their vision and hearing done, get some information and send them off to a speech pathologist. Or you could refer them to a multidisciplinary team, and locally that is a nice, easy option. Referring to speech is an absolute priority, because without a speech assessment we can't really start. It's helpful for me if I can have some context. That does several things. It tells me a bit about the family. It tells me how anxious they are about the problem. It tells me whether there are people in the family who have mental health difficulties, both in terms of the likelihood of their children having one, but also how they're going to cope with a diagnosis if that's what we end up with. So in Orange, if you're in 2800, you can send them off to Community Health, and they have a multidisciplinary team, which includes a clinical psychologist who will do the ADOS, which is a very detailed questionnaire, but they get a multidisciplinary team assessment, a report, and sent off to NDIS for therapy. Now that is an option locally, but it won't be an option everywhere. Anybody can refer, any GP can refer to Rural Far West. Tumberton, so that's Sydney Children's and Children's Hospital Westmead, developmental clinics do autism assessments. They'll probably want a paediatric referral letter. Aspect will take a GP referral. There are presently some free assessment places for healthcare card holders, I'm told. But any child psychologist who is a clinical psychologist can make a diagnosis and sign off on a diagnosis of autism, as can child psychiatrists if you can get into them. But of course, the most important thing is the speech pathologist. And in fact, my job is I'm much more useful because I don't do the ADOS, so I don't make a diagnosis. I will make a diagnosis if the child clearly has autism, severe autism. But as I said, most people are in the middle, and you need that ADOS and that multidisciplinary team. My job is I'm more useful once they've got a label to explain what it means, because often parents really don't understand that. Do their NDIS paperwork if it hasn't been done, but more importantly, to help with the comorbidities. And I'll talk a bit more about those sorts of things when we get onto ADHD. And those comorbidities can become more problematic as we get older. Treatment, not going to talk much about treatment. You can look it up, but simplistically, it's behavioural or developmental, and most families will need both. And then their outcome depends primarily on how their communication skills evolve over time, and you cannot predict that. So I have seen lots of 2-3-year-olds with almost no language who develop completely normal language over time, and others where it just doesn't progress at all, and I don't really know how you predict that. Certainly your outcomes are better if you don't have an organic cause for your autism, and you don't have other things going on. And it helps if you've got a few more IQ points to start off with. So that was a very rapid fly through autism. You've got some red flags to notice. Please make sure these kids can hear, and then refer them off to the speech pathologist, and then to wherever you think you can get them in, which I understand is challenging. And then importantly, once there is a diagnosis, catch up with the family. Parents have 1,000 questions. Parents may also have autism and it may not have been diagnosed, and certainly as a paediatrician, that's not somewhere I'm going to go. Then you can send the children back as they get older if other comorbidities arise. So that was deliberately a very rapid spin through autism, because we've got lots more to talk about when we get onto ADHD. But any questions about autism at this stage?
Feel free to raise your hands or type something in the Q&A. Stuart, I have a question. You mentioned that the diagnosis can absolutely be made around age 2, but often the diagnosis is not made until later. From a GP perspective, should we be trying to routinely use those screening tools that you'd listed, or is it more about observing the kids when they happen to be at our rooms for other presentations?
Oh, I think it's all of the above. Generally, child maternal health nurses will do a lot of the screening. Certainly, most daycare centres, it's something they are thinking about, they know about. But certainly, if you see a child in your rooms whose behaviour is odd, or whose parents are telling you that their child does odd things, then absolutely you can then just go through some of those red flags with them. I don't think that, as I said, I don't think your job or even my job is to make the diagnosis. That does require probably the multidisciplinary team, but we need to do the screening, and if we think that there is something untoward going on, send them off to a speech pathologist. And I'm always happy to somebody to ring me up and say, does this need taking further now? And usually, over time, it will become more obvious one way or the other.
Thank you. We've got a question here. Are there any comments, Stuart, that you may have on the theory of the relationship between the gut microbiome and autism?
I took that slide out because there's no question that there's an awful lot going on between the brain and the gut, not just in autism, in all manner of things. But I think our understanding is pretty rudimentary at the moment. And that's really why I haven't talked too much about the treatment of autism, because there's an awful lot of stuff out there, including funny diets, some of which I'm sure are effective in some children some of the time. I just don't think there's any good evidence for it. So it's not that there's evidence of harm, but it's just lack of evidence. So, obviously the Wakefield and the MMR and all that sort of stuff probably put the science back quite a number of years, and we've been paying the price ever since. But the microbiome is fascinating, and I don't know where that's going to go. Shall we carry on?
I think that's it for the questions for now, Stuart. Thank you.
Okie doke. So ADHD, and when I say that, I mean ADD as well, because effectively it's the same thing, just one has a bit more hyperactivity than the other. I see kids at different ages. I see that sort of hyperactive child, 4 or 5 year old, then they get to school and they can't do the work because they can't concentrate. They get more oppositional as they get older. And then the teenagers often will come on their own and say, I can't concentrate. And they know all about ADHD. And I've got a good number of teenagers who have responded well to medication for the first time when they're facing exams. I see considerably fewer girls. They will often come with learning difficulties. But the oppositional girl, where it's just odd behaviour, there's no obvious reason why they're so oppositional, it's certainly something to think about. These are the core features, and we'll expand on those a little bit. But critically, and this is something that you probably need to get to right at the beginning when families come to you, is that it's causing functional difficulties, both at home and at school. If it's just in one of those two places, it's probably not going to be ADHD. So how are we going to know whether a child's got ADHD? Well, we can go through the DSM-5 criteria, which I'm not going to because it's very dull. I can literally just use those as tick boxes if I chose to. It's all about their brain, and what we're looking at, all of those criteria relate to executive functioning, and that's, you know, a bit of a Pandora's box. It's all about how we plan, it's all about our working memory, it's all those sorts of higher level skills. So it's a brain problem. So there are plenty of people out there who still don't really believe that ADHD is a tangible problem, but it's a brain problem, and it's a brain problem related to the neurotransmitters in ways that we really don't understand yet. But it's fascinating stuff. We know it's a brain problem because if you do stuff to baby brains, or older brains for that matter, you can induce ADHD. And so all of those things can cause ADHD, and therefore preventing those things are a way of reducing the number of people with ADHD. But they are the minority, and primarily this is a genetic disorder. It's highly heritable. And again, it's not a specific gene. It's likely to be multiple genes, but it is highly, it does run in families in a very strong way. So most children who've got ADHD will have parents with ADHD, well, at least half of them, and most of those are unmedicated. So I'll come back to this in a minute, but if you function at that level, and I'm hoping you can see my hands, on without medication, and you function at that level on medication, most adults with ADHD stop taking medication and simply function at a lower level. So most adults with ADHD who know they've got ADHD will not be on medication. And unfortunately for a lot of them, that will cause them difficulties. But there's also many adults who are not diagnosed, who don't know they've got ADHD until their children get diagnosed. And if I had $1 for every time a mother says to me, "That's just like dad," enough said. So that is clearly your department, not mine. And I will often ask in my letters back to GPs that you make contact with parents about their own mental health issues. But there's also a genetic basis to all the comorbidities which run with ADHD, and things like learning difficulties are obviously also hereditary. It's very common. We stick to about 5% of the population ticking enough boxes for ADHD. So when you're making a diagnosis of anything in behavioural developmental paediatrics, is you tick boxes, and if you tick enough boxes, you get the label, and probably about 5% of kids would tick enough boxes for a label of ADHD. Prescriptions go up excessively, but it varies massively around the place, and that depends on how many paediatricians you've got and what access children have to them. Again, a bit like autism, it's much more common in boys. That's probably partly, at least, because girls are better behaved, even if they've got ADHD, and so they get missed, whereas boys tend to break things and get picked up early on. But there is no question it's more common in boys. Lots of things that you get with your ADHD, lots of other mental health difficulties, but also lots of other learning difficulties as a comorbidity, as well as a consequence. And I'll come back to that in a moment. So there's lots of specific learning difficulties like dyslexia, dyscalculia. And ADHD doesn't go away. And there is a little bit of evidence, although the criteria all say that it has to start in childhood, there are plenty of adults who clearly have ADHD and were relatively functional kids. Does it matter? Yes, it matters a lot. It costs us a fortune. The jails are full of people with ADHD, and all of those bad things happen if you've got untreated ADHD. And if you want to look at what happens in terms of school kids and learning, then there's a paper you can have a look at. What we don't actually have quite so good evidence about, surprisingly, I suppose, is long-term outcome data of what happens if you treat these kids. And presumably that's because they do okay and then they don't end up in studies. So it is important we make a diagnosis and find the appropriate treatment. So how are we going to do that? Well, same old, same old. However, this time, this is mainly my job. I'm going to base that on the information I get from the families, but also importantly, the information I get from you, but also schools, that school counsellor or the school psychologist. And I want to know how these kids are behaving at school, but also how they're getting on academically, and you'll see why in a moment. I'll then go through a whole detailed history, simple things, hearing, vision. Family history is very important because, as I said earlier, it gives me a context, but it also tells me how likely it is in the child. I'll come back to adverse childhood events in a moment, and I want to know how they're getting on in the classroom, both academically and behaviourally. I'll ask specific questions around behaviour. You know, can this child concentrate? Although it's amazing how long kids can concentrate in front of a screen, even if they've got severe and untreated ADHD. I think there are lots of people trying to work out why that is. Impulsiveness can be quite tricky because all kids are a bit impulsive. Again, a magic word, if a parent tells you my child just is driven, you know, these are kids who are relentless. They just never stop, hyperactive ones, but even the ones that are not so hyperactive, they're just buzzing all the time. And these problems have to be, just like in autism, occurring in multiple settings. Quick mention of the oppositional behaviours that you see in ADHD. If you get a label of ADHD, you kind of get oppositional defiant disorder chucked in for free because all kids with ADHD have ODD, partly because they do, and I don't think the tick boxes for ODD are particularly helpful or discerning, but more importantly, if you have a label of ADHD in a classroom, you get $0. If you've got a label of ODD, then the school gets some extra help. So the two do go together, they do overlap, and I would suggest that almost all children with ADHD have some oppositional behaviours. They also get anxiety and depression, they also get learning difficulties. And just briefly on learning difficulties, when we're talking about general learning difficulties, we mean you've had a cognitive assessment that shows you've got a low IQ, general learning difficulty, or you've had other tests when you've got a normal IQ that show you've got specific difficulties with literature, with spelling, with maths, whatever it may be. The latter are not well diagnosed in schools. They get missed all the time. So particularly the child who's had a language disorder, who then goes on to get into difficulties in the classroom, they're highly likely to have dyslexia, specific learning difficulty with literacy. That's a whole nother talk. It's therefore important that I know what their language skills are, and I will often send them off to a speech pathologist to look for those specific learning difficulties with those tests. I will always want something from school, and I really want the school counsellor to do an IQ test, be that a WISC or a Stanford Binet or whatever they want to do, because as you'll see why in a minute, that's quite important to me. And I can get some information from NAPLAN and those sorts of things as well. Now, there's no specific test here, but there are very well-used diagnostic questionnaires. And the Connors is the gold standard that we use, really. The strengths and difficulties is okay, but it's a bit brief and it will overdiagnose. You can just go through the DSM-5 criteria and tick them off, and if push comes to shove, I can do that. But generally, I like a Connors because I think this is an important diagnosis to get right. And despite all that, having all that information, I've then got to decide with the family whether any of this actually matters. So there's a scenario where you've got a relatively bright child who's got ADHD, who's getting on fine at school, who's just a bit of a pain in the classroom because he can get through the work and then he's faffing around. actually that may be manageable in that educational setting and the child doesn't need any extra help. Whereas the child who can't do the work and has only mild ADHD, actually the only thing that will help them may be treating their ADHD. So this is my paradigm. All abnormal behaviours overlap with normal, and we draw an arbitrary line between the two. So I'm a simple paediatrician. You tick enough boxes, you get the label. So I'm now going to explain that in exactly the way I explain it to parents. And I draw this as I go. I don't do it on the computer. I do it with a pencil and a piece of paper. So normal is a wide spectrum. We're all different. Short, tall, good at maths, anxiety, good at sport, whatever it may be. We're all different. And that depends on our genetics. That's kind of fixed. You can't do much about it. But it also depends on our environment. And that environment is our present world, but it's also our previous world. So I'm just going to digress slightly for a moment and talk about adverse childhood events, trauma in inverted commas. And we've learned only probably over the last 10 years or so just how important these things are. And this was one of the early papers. There's lots of others that you can read about. And when we're talking about traumatic events, those are the sorts of things on the list. And I mean, I don't think that's a complete list, but those are the ones that are, certainly in terms of research, are counted as adverse childhood events. And most of us will have faced one of those. A reasonable number have faced more, and the more you face, the sicker you get. And if you have lots of them, it's really, really bad for your health. So there's something going on here. And simplistically, if you're in the woods and the wolf comes out, you've got to decide whether you're going to run away or fight them. That's an adaptive response that will keep you alive. If the wolf is there every night, then you're constantly in that fight or flight mode, and eventually that upregulates your hypothalamic axis, and that is maladaptive, and it changes stuff. Again, a whole talk you could have on that. But it's important because it changes things. Now, the problem for me is that it looks a lot like ADHD. They have lots of very similar symptoms. So trying to separate them out is quite difficult. Now, one person who sent me questions beforehand, thank you very much, to answer the question of does treatment still work if it's trauma, the answer is yes. And I would always treat if I thought treatment was reasonable, and I'll explain why in a minute, because you'll get an answer pretty quickly. And if it makes a difference, it makes a difference, whether it's trauma related or pure ADHD, it probably doesn't matter. How do we know? Well, we don't really. I mean, clearly, if there's trauma in the history, that makes it a bit more likely. And if there's no trauma in the history, then it's ADHD. But the two can overlap. You can have both, no question. So in some ways, I think the issue here is that it's a semantic difference in terms of the diagnosis and my treatment, but it may mean you also need to treat the trauma. And that's never just the child, that's always going to be the whole family. So that's probably where it's most relevant. So back to my pretty pictures. Everything that's abnormal overlaps with normal. So in this context, we're talking about your educational ability, concentration, your behavior generally. So the problem that if you can't concentrate, you're not going to learn very much. But if you have a learning difficulty, particularly if you have a language problem and you don't understand the words that people are using, then you're not going to be able to concentrate. So that's a major problem. So the door in my office is open and I say to you, door, you know that means shut the door. A child with a language disorder knows that you mean the white thing in the corner over there, but they miss the fact that that was a command and it was a command for now. So language difficulties can easily be missed and they're going to cause big problems with your concentration. And when you can't concentrate in the classroom because you don't know what's going on, you're going to misbehave. That's what kids do. But equally, if you're impulsive and you're misbehaving all the time, you're not going to learn anything. So it's all very much chicken and egg. And so the reason that I need that cognitive assessment, and I need to know how this kid's learning is going on, is because if the Connors questionnaire is relatively mild and they've got a clear either specific or generalized learning difficulty, then that's an education issue. It's not a treat their ADHD issue. However, if their concentration is poor and they're impulsive and the Connors questionnaire is suggestive they've got ADHD, then they're going to need some help with that. And we'll come on to the treatments in a minute. Primarily Ritalin, some psychological input. And then we have to think about all the other things that are a consequence of this mixture of difficulties, the comorbidities. And they're pretty universal if you've got ADHD, and certainly in my experience they are, although almost always treating the ADHD first will lessen them, not always, but mainly. So we've got to think about the comorbidities. And then there's a whole heap of stuff in your environment, your day-to-day environment, that can be manipulated. And this is partly where a GP might come in and certainly where the psychologist can be helpful. So managing sleep, helping the family, a lot of these families are very chaotic, getting a social worker or some parenting going on, some parenting skills going on, very important. If there's drugs and alcohol, clearly that can matter. I can remember, I've had several children where I've treated them for quite a long time and then found out 2 years later that mum's alcoholic, and I never knew because I see her at 9 o'clock in the morning, there's nothing to see. So that's the sort of information I need a GP or others to tell. At this stage, well, again, somebody will have come to you and said, my child's got a problem, teacher says he's got a problem, or dad says he's got a problem, and you're going to provide the referral to me. So what do I need to know? Lots of stuff. I need a question. So Medicare, and this is just a little aside, Medicare are being much more difficult about referrals. So a referral doesn't have a question in, it's not a valid referral. And at the moment, they're just ignoring it. But at some stage, they're going to require that. I need information about what's going on at home, what's going on at school. As I said, I need that cognitive assessment from school. And ideally, I need that before I see them. On the day is okay, but 2 weeks later is not helpful. And a lot of referrals will say, I've asked the parents to do this, and that's fine. The problem is often it doesn't then happen. And there's not a lot of point me seeing them until it's been done. You can definitely make sure that their hearing and vision's normal, and you can provide me with a bit of background. Now, we have a pro forma coming out of this clinic, which we expect GPs to fill in because that's the only way we get all the information that we need. And that allows us then to triage the urgency and the severity of the difficulty and use the 1 or 2 appointments we have left for those most in need. But whilst you're waiting for me, and I realise that can be a long wait, there's lots that you can be doing. You can get stuck into the sleep. Sleep is so important. I'll do almost anything to get kids sleeping. It makes such a difference. Melatonin is a good drug. Again, a whole talk on that. I love clonidine, catapress, works wonders. Absolute lifesaver for a whole cohort of parents, because it gives them their evenings back and it gets the children off to sleep properly. Anxiety is best managed by a psychologist, better than drugs. And then you can help with the family. There's lots you can do for these families. A lot of them, as I said, will have ADHD, and you can address that. You can get them some help practically through Brighter Futures, those sorts of things. You can treat their parent. You can send the parents off to see the psychiatrist to start their medication if that's appropriate. You can fill in a carer's allowance form for them. You don't need a diagnosis for that. And you can get social work in, as we talked about. So these are papers that show that there's ADHD in parents and children, and you're not going to be able to have such good outcomes in the kids if you don't sort out the parents. So this is the guideline for treating, and yes, it would be lovely to have a comprehensive treatment program, but in the real world, we often can't do that. And often medication is where we're going to start. Having a psychologist involved is great, but it's probably not going to help a child with severe ADHD on its own. you're going to need both. And then there's a whole heap of other stuff, most of which has no evidence one way or the other. Most of it probably doesn't work, but just be a little bit careful about anecdotal reports of wonder treatments, because I don't think there are any. So this is where I start with medications. Short-acting and long-acting. So we start with short-acting and then we change over to long-acting. That's a Medicare requirement. Non-stimulants, atomoxetine I don't use very much because I don't think it works very much. It claims to be good for kids with ADHD and anxiety, but I'm not convinced. Catapres is an amazing medication used for all manner of things, which I'll come to in a minute. We were hoping that the long-acting version of that, guanfacine, would be fantastic. It's not that fantastic. It's used by some of my colleagues because GPs can prescribe it as a monotherapy, but actually it's most useful in that it's the only medication you can add on, so you can be on a stimulant and guanfacine. And most of the studies show that there isn't a lot of difference between any of the stimulants. Some say that Ritalin's probably the best, and certainly I will start with Ritalin. And those are the sorts of response rates you expect to see. I can't say whether the guanfacine and Strattera atomoxetine are those numbers, but certainly stimulants I would put around that. And so what I generally see is that 7 out of 10 patients I see within a couple of months of starting their medication say it's amazing, best thing ever, should have done it ages ago. The 8th patient, it makes a difference at school, but they don't see as much at home. The 9th, it probably doesn't do a lot, but when you stop it, people go, well, maybe it was doing something. And then the last one doesn't really help, and that's because ADHD is not the main bit of their jigsaw. It may be part of it, but it's only a small part of it. And unfortunately, you can never quantify whether if you've got a learning difficulty in ADHD, so you've done the testing for their learning and it's low and they've got ADHD, you never know whether it's 50-50, 90-10 that way or 90-10 that way. But generally I will treat with Ritalin in the first instance, because if that makes a difference, you'll know within a couple of months. And I'm happy to do that because I know all about the side effects of the medication. Basically, stimulants, the most common long-term thing is kids don't eat and they lose some weight. Most of them will put that back on over time. Some of them will get very skinny, and that worries parents a lot. They don't sleep well, this group, and that's why I like Catapres. It's very good to get kids off to sleep. I have seen some kids with panic attacks when they take their medication and we had to stop it, and picking at the skin, it's quite a common side effect, but generally it's pretty well tolerated. So those are the stimulants. Then we talked about Catapres, clonidine, or its long-acting version, guanfacine. Catapres is great for all of those things, and I'll sometimes use it in the kid who's 4 and 5, who probably does have ADHD, but I don't want to treat with stimulants because they're a bit young, and clonidine will help. The problem is you have to use it every 3 hours or so. It was hoped that guanfacine would be a great panacea, but actually it's been a little bit disappointing. Issue with Catapres at bedtime is it makes you sleepy, which is great. It can give you nightmares. I've never seen rebound hypertension. Guanfacine has to be used 7 days a week, unlike the stimulants. And one of the great things about stimulants is you can just use them Monday to Friday, and they will work just as well on a Monday, whether you used it over the weekend or not. Guanfacine you're supposed to use 7 days a week because of the risk of hypertension, but I don't know if that's real. I fix the morning dose first. I see them 6 weeks later, and if the morning dose is working, and I'll know it's working because schools say great in the mornings, terrible in the afternoons. And I warn the parents about all this. I warn them that their behavior will be terrible for the first few weeks because kids on stimulants get lots of emotional volatility. They've just got to get through that. Most of that will settle down over time, and then we can change them over to a longer acting capsule. And most people will do that. Some people will start them on twice daily short acting. To me, that can make it a little bit harder to know that it's effective. So that's just how I manage it. You can then do all the psychosocial stuff, for which there's a little bit of evidence, and you can certainly provide some supports for the family. Cognitive assistance for these kids, until you've managed their ADHD, is not going to be particularly helpful. So ADHD, clear diagnosis, needs to be done properly because it matters. You need the information from the school counsellor as a must. And then we've got some great treatments for it. You know, I spend a lot of my time writing stimulant scripts, which is boring as hell, but it probably does more good, big picture, than a lot of other stuff that I might be doing. And so, you know, I find it very frustrating that we can't provide treatment for all the kids that we want to. We don't know what happens if you treat kids. We kind of lose them to follow up, but untreated ADHD is really, really bad. So we've got time for some questions on ADHD, and then I just want to finish briefly in a moment to talk about why you can't get kids seen when you want them to be seen by a paediatrician.
We've got a question from Amanda. If you have two parents who both have ADHD and they present with concerns, the toddler or preschool age child might have ADHD as well, either based on their behaviour or genetic risk concerns. Is there a role for any meaningful early intervention and assessment, or is it about optimising everything else?
Absolutely, the early intervention is help the parents. You know, parents with ADHD find life really, really hard, and they're going to provide a chaotic environment if they've got untreated ADHD that's going to compound all of the problems that that toddler has. So all the effort needs to go towards the parents. There's nothing you can do about it. You can't predict that a difficult 2-year-old will have ADHD when they're 6, but all 6-year-olds with ADHD were difficult 2-year-olds. So I won't use stimulants under 5, and I'll try and avoid them till they're 6 if I possibly can. What I will do in the 4 and 5-year-olds, particularly if there's carnage and they can't go to daycare or preschool, is I might use catapress in small doses during the day. It works really well. It's not without its risks in that you've got to keep it locked away because you don't want to overdose on it. You know, 3 tablets of catapress can kill a toddler. So you do have to be a bit careful about it. But that certainly, you know, will play for time whilst we try and get some help for the parents. I will often send preschool kids to see the psychologist, but it's not for the child's benefit, it's for the parents.
Thanks for that. And we have another question here. Your comments on the role of behavioural therapy in treating ADHD, what sort of effectiveness are we looking at?
I think if you've got moderate to severe ADHD, I'm spoiled. I've got some fantastic psychologists in town, and they will pretty universally say if they've got moderate to severe ADHD, they're wasting their time until we put them on medication and slow them up enough that they can take on some of that extra help. There was one slide which I went through very quickly. There isn't a lot of evidence that behavioral therapy makes a big difference. It's an add-on. So some of the original big studies showed that stimulants work really well. Stimulant plus psychologist worked marginally better. Psychologist on its own was less effective than the stimulants. So yes, they have a role. Again, I think a lot of that is around parenting, and also psychologists going into schools and helping teachers cope, because teachers, you know, it's pretty hard. You've got a class of 30 kids and one of them's got ADHD and is running riot. It's very hard to help that child, and so giving them some support can also be useful.
Mm-hmm. Now, I hope I'm interpreting this question correctly. Consider the patient who's recently moved into the region. They're in a non-English speaking background, and the child's behaviour is very disruptive, and academically they're not doing well. What sort of approach should we take with that child?
Well, I guess this is one where you're trying to work out whether the environment is causing the problem, be that having emigrated or moved or not having good language skills. All of those can manifest in behaviours that look like ADHD or anxiety or anything else. So trying to pick that all apart is the first thing, and that can be quite difficult, but psychologists are really good at that sort of thing. I'd certainly want to know what's going on at school, because I see quite a lot of kids who actually are just tyrants at home, but are actually particularly well behaved at school, and that's always reassuring. Makes it a bit harder to treat because it's not ADHD and it's an issue of parenting, and that's much harder to deal with. So I think in those sort of complex kids, you do need a psychologist involved. You do need to know what the social setup is. You do need to know what their language skills are. So a speech assessment is important because, as I said, it's easy to miss language difficulties. Clearly, if they don't speak English, then that's going to be a big part of the problem. If, having said all that, the features of ADHD are still there, I don't think I've got anything to lose by a 6-week trial of medication, because one of the things I love about Ritalin is it's usually pretty obvious. It either works or it doesn't. And the way I do it, you can see this difference between the mornings and the afternoons. And if that's the case, then you've made some benefit to this child, even if it's only a small part of the big jigsaw. But complex kids are complex and they're difficult to manage.
Mm-hmm. Okay, I've got a question about, we were talking about sort of differential diagnoses. How do you distinguish the child with bipolar disorder and ADHD? And what would the role of the role be for a mood stabilizer such as valproate in treating ADHD?
So there's no evidence that any other medications other than the ones that I've mentioned have a primary role in ADHD. If they've got a comorbidity, so let's say they've got severe anxiety, then you may also need a medication for their anxiety. Bipolar is not, so kids with severe ADHD are going to present by primary school age without any question, whereas bipolar is much more of a late teenage disorder. We do occasionally see it in younger kids, but not very often. And so if I've got a sort of young teenager who I've been treating for their ADHD and there's now something else going on, then I'm probably going to get a child psychiatrist to see them, because it's not an easy diagnosis. And they may then use all manner of other medications, but almost always continuing the ADHD medications. So it's not likely that they're going to have one or the other, and I have to make that decision. They're going to have ADHD, and then they're going to evolve into having a separate bipolar disorder as they get older.
And I've got a question of my own as well, Stuart. I'm curious to know, in my experience, often the parents who come along concerned about the child's behaviour, it may well be to do with the parenting style, parenting issues. What's your comment about that? Is that something that you've seen commonly?
So I almost always say to the parents, parenting is the hardest job in the world. I have behind me 50 parenting books, all of which I read, most of which you just go, well, yeah, I kind of try that, or it doesn't work in our family. Parenting is incredibly hard. It's a game you're designed to lose, and parents don't know that. And it's just, I'm trying to be as empathetic as I can, and I always provide them with some written handouts, both on ADHD, but also on the parenting side of it. And I try gently to explain that as parents, most of what we do doesn't. So the risk with parenting is that most of what we do makes things worse. So every time we intervene to stop a fight at home, we are almost invariably shouting at our kids, telling them to stop, to tell them to stop shouting at their siblings. So clearly we are not providing a good environment, and we're not providing a good way forward. So I try and explain that parenting is incredibly difficult, but that if they aren't willing to try and look after themselves as the adults, then there are going to be consequences. Now, I'm relatively gentle doing that. I have to say, our psychologists here are much tougher than I am. They will say, you've got ADHD, you've got significant anxiety, here's what you've got to go and do about it, and I will treat your child when you've made a start, because otherwise they're wasting their time. So again, I throw that back to the GPs. I will say in my letters, please could you talk to mum about her mental health because she seemed very anxious today, or whatever it may be. But you can't ignore it. It needs to be addressed, and it's really, really hard.
Mm.
Ask my kids.
Thank you. And from Tammy, do you find there's much pushback from parents when prescribing stimulants, especially from the parents who've had a bad experience with their own stimulants as a child?
Yep, I do, and I spend a lot of time going through it with them, and I will often send them away with the information and say, come back in a month and let me know. Or occasionally I will never push them into it. I will, if I think the kid's got severe ADHD, I will tell them that I don't think anything else will help them. But I will also tell them that treating them today versus 6 months' time or a year's time will make no difference in the greater scheme of things, except that they will have a potentially miserable 6 or 12 months, which we could avoid. So if they've got mild to moderate, no, absolutely, I won't push it. And parents will often go away and think about it. And the teenagers, and I probably should just mention this, is that compliance is clearly an issue with the older kids. So I will always get them in, year 9 or 10 to stop their medication for a couple of weeks and then go back on it and find a teacher they trust and a mate that they trust to find out if they think that they should stay on it. Because you need teenagers to buy in if you're going to get them to take it long term. And of course, the problem is, and I have to do that before they get to 18, because when they get to 18, they suddenly have to find $400 to go, $600 to go and find a psychiatrist to get a script. And they've seen me free for the last 12 years, and that's a big problem. And so most of them are going to stop their medication unless they really, really know it helps. And of course, that's the problem. Most of them will stop their medication and function at that lower level. I might just finish off the next couple of slides quickly to explain why in our region, these kids are unfortunately not getting to see a paediatrician at the moment. And ooh, what's going on here? Why am I not moving forward? There we go. So historically, when I arrived here, we went up by 25%, and suddenly we could see everything, and so we did, and that was fabulous for a number of years. And then Des retired, and he had loads of patients, and so this is a problem in every rural site. When consultants who've been there for 25 years retire, they've got loads of patients, and their replacement is never going to see all of those, so you have a sudden jump up in the number of patients that everyone else has to see. And we tried to funnel everything into our PACS clinic if we possibly could. Alan went on and did some other stuff, and so that reduced the clinic capacity a bit, and Julia started working part-time, and at the moment we can't fill the other half of her job, which is a problem. But none of that is the real problem is that we have to prescribe stimulants every 6 months, and that's at least half of our patients are on stimulants. And we see them when they're 6, and we see them for as long as they take their stimulants until we kick them out at 18. So simplistically, and don't look at the numbers too carefully because I don't think it adds up, but anyway, if you start with 20 new patients and 40 old patients a month, and then 6 months later, half of this group you have to see because they're now on stimulants, then you've got 50 follow-ups, and then 12 months later you've got 60, and within 2 years you're full. Don't worry about the numbers. Now, we actually know that that is exactly what happens because we got some extra funding for a couple of years, and that's what we got for 0.4 extra, and they filled up. So what have we tried? Well, we tried sending out a script in the middle and just seeing them every 12 months. That takes the same amount of time from my point of view. I don't get paid for it. The hospital doesn't get an occasion of service, so it doesn't look like we're doing any work. And most of the families still wanted to have a chat at some stage during that year. So that really wasn't terribly successful. So what else did we do? We shoved everything into PACS that we could. We sent everything to a psychologist before they saw us. We deferred things by saying we need the assessments first. That bought us a bit of time. And then we just stuffed them into clinics that were already full. We begged the hospital And now we're at the point where we're just having to say no. So what did the hospital do? Well, we had loads of meetings. The ACI came in and did a project, and it wasn't worth the paper it was written on. Then we had another project group, and out of that we got Anna for 0.4, and that worked really well for a couple of years. But as I said, she's full, and then the money ran out for a month, which didn't help. So where are we going to go? Well, at the moment we're just cramming extras in. This is the medical patients, and we're just saying no to anything that's not medical. And mistakes are going to get made. We're just too busy, and somebody's going to burn out. So one of the options is that we see patients once, give them their labels, diagnoses, and say, off you go. That would be really hard because that wouldn't come with a script. And so I don't know if that's ethically an appropriate thing to do. There's no question that some of my colleagues, and this, we're unusual, we're an entirely staff specialist clinic here. There are no BMOs in this region. I don't think there's even any in Dubbo now. So, but I think people will give up being staff specialists and go and work privately because it's just too hard. And then there's the issue of GP prescribing, which sounds like a really good idea. And I know there's pilots happening around the place. It's a massive amount of work to set up, and I think longer term it's a must. But the problem is you have the same problem we do. Unless you can guarantee that it keeps going, then you're going to fill up with kids with ADHD, and that's not actually what I think you should be doing, because I want you to look after me. I don't think that looking after ADHD is a good use of most GPs. Now, forgive me if I say that and it's inappropriate, but I just think that you do so much kind of holistic stuff across the ages to take a big group of kids with this problem. I'm not sure is a great use of a GP's time. Some shared care, absolutely, but I wouldn't want to see your clinics fill up like that. So you might, the pilot would be 2 years. Is that better than nothing? Maybe. And it may be that in 2 years' time, after the pilot's gone, there are some VMOs in Orange who can take over. But longer term, we've just got to decide if we're going to pay for more capacity to see this group of kids. And that will require a change in the model somehow. Or we have to say it's not a medical problem, and this is what both hospitals say, is we're here for acute medicine, we're not here for the clinics, and we don't generate much income for the hospital, so they're really not that interested. But of course they will pay in the long term, because they will get the 14-year-old coming in with his suicidality, or he's stabbed somebody or whatever because he's no longer taking his medication, and we do see that from time to time. So unfortunately I get phone calls from juvenile justice all the time about these kids who are no longer taking their medication. So it's a problem countrywide. It's a particular problem in Orange because we could do everything for 15 years and now we can't. Whereas in most country towns, you would never refer somebody for ADHD because you wouldn't get them seen. So unfortunately, things here have got as bad as they are in the rest of the place.
And that burning question, where are the solutions? Anyone on the floor who are willing to make some suggestions there? Silence on that front, unfortunately, Stuart. There is one other question that has popped up in the chat, and it's a question about selective mutism in teenagers. Could that be due to autism, ADHD?
Well, probably not ADHD. I think that would be an unusual combination. I mean, selective mutism is not uncommon, and it's usually in the context of anxiety and social upset, in inverted commas, of some nature. It is more common in kids with autism. It would be an unusual thing to appear as a teenager who nobody has noticed they've got autism. But as I said, it's a spectrum, and so maybe they've had relatively mild autism. So it's certainly something to think about in that context. But it won't be the autism that's making them mute. It will be either something that's going on at home or school or anxiety or a combination of all those things. Autism itself doesn't cause selective mutism.
Thanks for that, Stuart. I'm just mindful of time, and we do need to move on to the next part of our presentation, but we'll certainly have the opportunity to come back and ask a few more questions if required. So just moving on to Tammy and Sonia, thank you very much for joining us and filling us in about the RuralKidsGPS service.
Thanks, Ivy, and thank you, Stuart, as well. Excuse me, I'm just perfect timing to start losing my voice. But thank you, Stuart, for letting us follow on from your presentation. That was really good to listen to and very informative, so thank you. So tonight we just wanted to tack on to the end of this as well, just so we can give you a little bit of an update around our new paediatric care coordination service that we have running in the LHD at the moment. It is a little bit of a trial program, and we have funding for 4 years at the moment. Sonia is our care coordinator, who is working with us part-time capacity. She does a wonderful job, and I'll hand over to Sonia, who will be able to give you a little bit more information around the service.
Thanks, Tammy. I'll probably go through this quite quickly, but I know you'll have access to these slides. And you know, I'm always just a phone call away if you need any more information about the service. Okay. So I just wanted to acknowledge that I didn't make this presentation up myself. I did get some help from some of our other colleagues from other LHDs. So I guess what is RuralKidsGPS? So my background is paediatric nursing. So I've been a paediatric nurse for quite some time now and moved into care coordination down in Murrumbidgee in 2017. So been doing it for a little while now, but I just started in Western New South Wales in February. So it's brand new to the district. And we care coordinate for children with medical complexity. So I guess a total different cohort of children to what Stuart was just talking about. And we really do focus on the medical complexity side of it. So they usually have some sort of technology assistance. They usually have a diagnosis that's going to last, you know, longer than 12 months. They're normally going to our emergency departments quite frequently, and they usually have multiple teams across different sites. So that would be locally and at the tertiary centre as well. So then we have the other arm of the program, which is the research arm, and that's going to help us evaluate, hoping to then help us get some permanent funding for the service after this, I guess, the study finishes. So that is looking at health service utilisation data, so seeing if we're making a difference from, you know, really increasing their local care rather than travelling backwards and forwards to our tertiary centres. And also look at family satisfaction and also their quality of life. And it's also important to look at the cost effectiveness as well. So brief history. So basically Kids GPS, which stands for Kids Guided Personalised Services, was developed by the Sydney Children's Hospital Network back in 2015. We did do a project in Murrumbidgee in 2017. We got some permanent funding. Southern also had a little trial of it for a year, but weren't successful. So now with the network and the University of New South Wales, the RuralKidsGPS project was funded by a TRGS grant and some priority funding as well. So yeah, basically it includes 4 rural LHDs, and Western is one of those. So I guess why did it start? Obviously, a few quotes there from families, and you know, I'm sure you're very well aware that some of these families, it is a real struggle. You know, especially that backwards and forwards to the tertiary centres, and even for some of our families, just backwards and forwards even to our base centres, so to Orange, Dubbo, or Bathurst, you know, where their paediatricians are located. We are lucky that we do have some outreach clinics, which are quite helpful. So basically, the number of children living in our areas is increasing, and most of the time there's lots of health silos. Like I said, there's multiple teams involved, and the communication channels between all these teams are quite difficult. And I'm sure as GPs, you don't have access to our medical record system, and that causes a few issues. And obviously, that leads to dissatisfaction for the providers as well. A lot of these families normally have a big, massive folder with all the letters from every single specialist they've been to. And, that's when they present to our emergency department or to your practice, we don't really typically have time to read through all that stuff. And obviously access to paediatric services within rural areas is a real issue as well. We know that, people in our rural LHDs experience higher out-of-pocket costs because, they're travelling, long distances. They've got to stay overnight down in the tertiary centres, and they've usually got to have a couple of days off school and days off work for the family. So, they really are out-of-pocket, quite substantially different to our metro counterparts. And that's just pointing out that, obviously coordinated care can have an impact on the health system as well. And it's all about trying to save, out-of-pocket expenses for the family, but also some dollars for the health system. We coordinate things much better. So I guess the model really uses what we call the circle of coordination, which is on the screen at the moment. This was developed by the Sydney Children's Hospital Network, and it really just puts the young person and the family at the centre. And then we help them identify their leads. So that will include a family lead, a tertiary centre lead, a community lead, and also a local hospital lead as well. So the care coordinator's role really is just to guide them through all this stuff and help them put all the puzzle pieces together. So we've got a case study at the end. Hopefully we can go through that. We've got time and go through a few things that we helped one particular family with. But yeah, basically it is all about helping them navigate, educating them, helping them communicate with their teams, and also being able to advocate as well. And I guess at the end of it, we really want the family to be able to have the capacity to do this themselves. We don't really want them on the care coordinators, their whole paediatric journey. Can help them, with some of these things, for their first trip back to the tertiary centre, for instance, then they should be able to do it themselves in the next time they have to go. So I guess the criteria for referral is a diagnosis expected to last at least 12 months. And I guess sometimes these families are awaiting that diagnosis, but usually there would be a multidisciplinary team review that they would have to attend the tertiary centre for. And usually, I don't really go looking for the health service data, but usually I know that they've either presented to ED a few times or they've been admitted to hospital for a lengthy period. And most of the time they would have had 2 or more outpatient appointments, or that is what they're referred for to help us or help the family organise those appointments. So how do you refer? It's currently direct referral to myself, and we also have a joint email address there that is accessed by our paediatric clinical nurse consultants as well, just for when I'm on leave and things. And that is my phone number. So we have got these flyers, which I think have been provided to the PHN, but happy to send them out again. We do have ones that you can give to the families as well as ones for the staff as well. So happy, if you're not quite sure if they're eligible for the service, please just give us a call. Happy to have a chat as well over the phone. So we have a case study. You're all happy for me to run through that brief. Just might help put it into perspective a little bit. So this is a little one, a 7-month-old who had been inpatient at Sydney Children's Hospital Network since birth. We referred this, we got this referral from one of the clinical nurse consultants at the network. So a little one with Hirschsprung's disease, had multiple surgeries, has multiple teams involved, and has a central line on TPN, has a PEG tube and also has a colostomy as well. So got a lot of tubes coming out of him, poor little bugger. And the family are planning to return home to the local community. And yeah, I guess the parents had concerns about coming back to the LHD, and also the tertiary teams had some concerns as well. So we have an intake meeting tonight, so that our paediatric CNCs and also a paediatrician, and we go through all our referrals. So we discussed this little one. We notified our paediatric ward locally, just so they could, say any concerns if they had any. We let multidisciplinary teams know, and then we made contact with the family. And we discussed some of their concerns and tried to alleviate some of the anxieties around coming back to our LHD. Then we developed a integrated care plan. Now, this was quite tricky because it really reflected a tertiary model of care. So this little one had been discharged from the hospital to a tertiary location, so not far from the hospital. So that they already had a care plan developed, but it was very tertiary based. So we had to really, really advocate quite strongly and quite hard to make sure that it, fitted in with our LHD. And then after all that, it was a lot of work, but after 10 months, at 10 months old, he finally went home. And I guess that was the first time this family had ever taken their baby home. So, and 10 months old. So they were finally home, everyone was together. So then we organised, we let them, be at home for a couple of weeks. Then we went and met with this family face to face because we knew about all the anxieties and the fears about presenting to our local emergency department and local paediatric ward. So we met with them. We really nutted out what their, challenges and concerns were. Some of them were not a surprise, but some were quite a surprise to us. So, access to their medications. So one of their medication costed like $1,400 annually. And that was not even stocked at our local hospital. So we had to nut that one out. And they really were asking about, well, what if I can't get into my GP? What if I don't want to go to emergency? What if it's just something that, in between, GP should be able to sort out, but just can't get the appointment. So we had to nut that one out. And we thought that was a really fair question. We had to work out where they were going to go for their regular pathology, and one really interesting one we thought was Dad was worried about the medical waste at home and how they were going to get an extra bin. And just doing the electricity company, equipment value plan, IPTAS, sorting out the IPTAS claims. So what did we do? So the medication we applied for compassionate supply through our base hospital pharmacy. We did a non-emergency plan, which was basically referral to our paediatric hospital and home service, or in this LHD, it would be PACS. We recommended the local pathology service that were good with children. We organised a support letter for their medical waste and helped them with their local council application to get another bin at home. We did, for the electricity, we did the life support registration and the rebate forms. And the equipment value plan. So that was more around the feeding pump for the gastrostomy feeds. What happened if it broke? What we do? So we just liaise with the local dietitians and come up with a 24-hour plan, really. So covered the weekends and everything as well. And we helped them with the IPTAS, which was a little bit complicated, but we got there in the end. And obviously then we had to update the integrated care plan. So there was lots of work we did there, and I guess the outcome was that they were home together. The family expressed, how grateful they were for the localised care plan, and they did admit that it reduced their anxiety and made them feel more in control. Obviously, they appreciated the paediatric team support, and Mum really thanked us to make that referral because, again, that we really had to advocate for that as well. And he did have one emergency admission to the local hospital. That was quite smooth, and the parents were really happy with the care they received. So now, where are they up to? So they've been now 14 months old, been home for around 4 months. They've had one trip back to the network, and that was for a central line blockage. So, nothing we could have done about that locally. Now up running around, so not walking, running, which, with just thought with this particular child that the motor development might be a little bit delayed, but not with him. He's eating a normal diet and they can't stop him eating. And he's now up to, I think it's down to 24% parental nutrition. So really, really good outcome. No planned follow-up at the network, only by telehealth, having the bloods locally and the weights have been done as well, and just liaising with the tertiary dietitian through email. So really, really good outcome. We were set up for the worst because obviously this little one could have got really sick quite quickly. So yeah, thank you. So I guess in a nutshell, a family with a medical complex does like having a messy Tupperware cupboard. It's a mess of appointments, trips away, juggling work, other children, really is chaos for them. So we all know how stressed we are when we're busy and we can't find the lid to that container. So I guess the service really is about helping families organise that cupboard and taking some jobs off their list to do. We really help them get their ducks in a row, you know, because they really do have a lot on their plate, these families. So we just try and help take the load off a little bit. And I guess, you know, what's easy for us is not always easy when you put it, you know, from the family's perspective. So, so I'll stop talking there and see if anyone's got any questions. And sorry, hope that I didn't go too much over time.
Thank you so much for that, Sonia and Tammy. That sounds like a fantastic service for our very complex patients. And Stuart, I had to smile reading your comment/question because it's certainly what we face all the time as GPs in terms of lack of information flowing through. Did you want to ask that one yourself, Stuart?
Yeah, so the question really was how you know what needs to be coordinated. Clearly, the teams all need to tell you what's needed, but we really struggle with that because we don't get timely letters from the children's hospitals. So I'm just interested to know how you know what needs coordinating.
It'd come in all directions, I guess, Stuart. So normally the family most likely tell me, but as you know, all of these families don't have capacity to be able to do that. So it normally would come from the network. Hopefully there is someone that knows about us or knows about the network care coordinators, and we'll make that referral through them. And yeah, obviously you guys, when I get a letter from the paediatrician or a phone call, yeah, it really is, I guess, can be messy.
I mean, I guess
but usually if I find
my kind of unwritten hope was that you would be able to advocate for those teams to communicate in a timely manner.
Yeah, unfortunately, it's just the delays in, you know, getting their letters typed up most of the time. But in saying that, I can read the Sydney Kids EMR. So if they've documented in the medical record, it's great, but they don't always do that either. So it really is sometimes just, yeah, a lot of phone calls to the specialist teams if I need to find out when they want to follow up. So yeah, I guess I do sort of do that. What you're saying.
Thanks so much, everyone. It's now hit 8:30 and I think we're getting the wind up from our coordinators here. I'd just like to finish off by saying thank you so very much, Dr. Chris and Tammy and Sonia, for your fantastic presentations this evening. It's been very, very enlightening and above all, very locally relevant to the patients we're looking after. Just a reminder, everybody, your feedback is important. So if you could scan the QR code there and provide your feedback, that would be much appreciated. And thanks everyone for those comments. And we'll draw things to a close. Everyone keep safe and warm and well, and we'll see you at the next GP Masterclass. Good night all.
Thanks all.
Thank you all.